I'm under Paixao. I'm one of the cardiologists at the Heart Hospital, and I'm going to talk about the now not so new guidelines on the measurement of blood cholesterol. A little bit of an introductory slide. Why is this relevant? Even though all forms of cardiovascular disease are declining in the United States, it is still estimated that over 85 million Americans have at least one form of cardiovascular disease. And currently, the combination of heart attacks, strokes, and other forms of cardiovascular disease account for 1/3 of deaths in this country. It far surpasses cancer, lung disease, and kidney disease deaths. This is even more relevant in the state of Arkansas. Unfortunately, we are among the top 5 states in the nation with the worst cardiovascular statistics. A little bit of historical background. The way we approach cardiovascular disease nowadays was heavily influenced by what happened in this country in the mid to late 40s. When President Roosevelt died of complications of uncontrolled hypertension, our knowledge of risk factors for cardiovascular disease was quite poor. His death, however, triggered a surge in cardiovascular research and culminated in the funding of the Framingham Heart Study. The Framingham Heart Study started in 1948, and it pretty much identified the risk factors that we use nowadays to prevent cardiovascular disease. Knowledge of these risk factors, however, is not sufficient to predict individual risk for a patient. If you take, for instance, a moderately healthy woman with a low baseline risk of 1% over 10 years, even if that risk is doubled by the presence of hypertension, she still have very low baseline risk. If you take a man with a higher risk factor burden, even in that man, the presence of hypertension and that doubling of risk will be much more clinically meaningful. And to integrate all the information from those risk factors, Peter Wilson published in 1998 the Framingham Risk Score. This allows us to really get an output of what an individual's risk is, combining all the risk factor burden. For instance, a 49-year-old woman with ordinary cholesterol levels who's a non-smoker, even with quite elevated blood pressure levels, will still have low 10-year risk for a cardiovascular event. On the other hand, a man of similar age with slightly worse lipid panel who is a smoker, even if he has ideal blood pressure levels, his 10-year risk is still substantially higher, 20% over 10 years. And this really impacts how we approach cardiovascular prevention. In that woman with low baseline risk, even a treatment that has a marked impact, a 35% relative risk reduction, will have a very modest and likely clinically insignificant benefit. In a man with higher baseline risk, that same intervention will have a much more substantial absolute risk reduction, and it's likely to be beneficial. And that principle really informed all guidelines that have come out since 2001. ATP3, which are the guidelines that have been in place prior to 2013, used this principle to come up with 5 risk categories. Each risk category was assigned an LDL target, and in higher risk categories, medical therapy, cholesterol-lowering medications were more aggressively recommended. This has some limitations, though. If you take, for instance, a 60-year-old man with ordinary cholesterol levels, an LDL of 90, he's a smoker, he has modestly elevated blood pressure, even though his 10-year risk for a coronary event is 25%, he's still not recommended treatment with a statin. This patient profile well fits into more recent studies that demonstrate a substantial benefit from statins. You can say that this never happens, this patient does not exist. That's not true. We published a few years ago this paper. We used data from over 400,000 patients presenting with a heart attack in this country, and if you use the risk factor burden prior to that index event, only 20% of patients would be classified as high risk by the Framingham Heart Study. Even if you include patients with established cardiovascular disease or diabetes, only 60% of patients would have an indication for statin treatment prior to that index event. Furthermore, decades of research into statins and other cholesterol-lowering treatments does not seem to support the concept of LDL targets. There's really does not seem to be an interaction between a baseline LDL level and the relative risk reduction you would get from treatment with a statin. You can really observe the same relative risk reduction for LDL levels under 70 and over 130. This has been further corroborated by recent studies. In the IMPROVE-IT study, treatment with ezetimibe resulted in a statistically significant relative risk reduction even though the achieved cholesterol levels were under 50. In the HOPE-3 study, a population with intermediate to low ASCVD risk, around 12% over 10 years, achieved a 25% relative risk reduction from treatment with rosuvastatin. This population would, by and large, not be eligible for statin treatment under previous guidelines, but is within the recommended treatment for the new guidelines. So in 2013, a group of enlightened individuals came up with these guidelines. And what they basically did is identify 4 groups of patients in whom there's likely to be a net benefit from treatment with a statin, meaning there's likely to be more benefit than harm. And those groups would be those with clinical atherosclerotic cardiovascular disease, so heart attacks, stents, bypass surgery, prior stroke, or peripheral vascular disease. Those patients with an LDL over 190, that group often falls into the genetic elevated cholesterol patients. Those with age over 40 and diabetes, and those with age over 40 and a predicted risk over 7.5% over 10 years. Where does the 7.5% come from? It is relatively made up, but based on solid data. 7.5 is the threshold above the number of prevented cardiovascular events is likely to comfortably surpass the number of statin-related new diabetes cases. And it really is a very conservative estimate. So this is an overview of the recommendations, what's old and what's new. The new guidelines is also a risk-based approach. It's also based on a 10-year risk prediction, and it uses the same traditional risk factors identified by the Framingham Heart Study and present in the Framingham Risk Score. What is new? It's a new calculator. It's called the pool cohort equations. It's race-specific. It has beta coefficients for Black and non-Black individuals, and it includes stroke in the estimate of risk. The Framingham Risk Score only includes MI and coronary death. Now we include MI, stroke, and death from MI or stroke. The threshold for treatment is lower, 7.5. There are no LDL targets, which in my opinion is a better reflection of the data we have. And it focuses on statin treatment, because those are the most extensively studied cholesterol-lowering medications we have. So what happens if you apply this in the US? So by adopting the new guidelines in detriment of ATP3, around 12 million Americans are newly eligible for treatment with a statin. That's a modest 29% increase. This was published by Michael Pansina in the New England Journal of Medicine in 2014. A few weeks later, we published also in the New England Journal of Medicine that actually you get the same increase if you just adopt the optional goals in ATP3. So even though at the time this sounded like a very drastic and radical recommendation, it was already sort of in there in ATP3, but not quite that well adopted. So what happens to those patients who are newly statin eligible? So using data from the Dallas Heart Study, we estimated that by adopting the new guidelines in detriment of the old guidelines, you're actually going to prevent between 3 and 5 atherosclerotic events and only cause 0.5 to 1.5 new cases of diabetes, a really significant net benefit. There are limitations to these guidelines. One of them is the overestimation of risk by the new calculator, especially in the intermediate to high risk group. This is fairly controversial, but has been replicated in a number of cohorts. However, we do have a tool that can help us get around that. If you submit patients in the intermediate risk group where you may be overestimating risk to a calcium score CT, you can identify a group of patients without any calcium in whom the observed event rates will be quite low and separate them from patients with some calcium in whom the predicted event rate will actually match the observed event rate. This is also true for a slightly higher risk category, and calcium score has really been proven to be quite useful here. So in conclusion, the new guidelines are not perfect. The pool cohort equations may overestimate risk, although you can sort of go around that and fine-tune your risk prediction with a simple CT. It's highly focused on statins. It does not include strong recommendations for ezetimibe and perhaps the newer PCSK9 inhibitors, although these therapies have not been proven to be as effective, or statins or had not been proven to be effective yet. In my opinion, this is clearly an improvement on prior documents and better reflects current evidence. It emphasizes a risk-based conversation. The idea is to present the patient with his data and the potential benefits, potential harms, and make a shared decision. This is quite a buzzword nowadays. And we're basically recommending a proven intervention when the expected absolute risk reduction is likely to surpass the predicted harm. And that's what I have.